Anemia, aplastic symptoms and signs are due to and relate to the severity of the peripheral blood pancytopenia. Fatigue, shortness of breath on exertion, headache, palpitation, symptoms of anemia. Easy bruising and petechiae, gum bleeding, buccal hemorrhage, visual disturbance due to retinal hemorrhage, symptoms of thrombocytopenia. Mouth and tongue ulcers, symptoms of infection due to leukopenia. History of jaundice, may indicate post-herpetic aplasia or associated paroxysmal nocturnal hemoglobinuria. Signs: pallor, ecchymoses, petechiae of skin and mouth, retinal hemorrhage, bleeding. Manifestations are usually more common than infection. Fever, mouth and tongue ulceration, pharyngitis, pneumonia, skin and perianal abscess. Skeletal, skin, and nail anomalies, short stature, may occur in congenital. Aplastic anemia. Spleen, liver, and lymph nodes are not enlarged. Investigations. Full blood count and examination of blood film shows pancytopenia, isolated. Cytopenias may occur in early stages, macrocytosis, mean corpuscular volume greater than 100 FL. Respiratory count shows absolute reticulocytopenia. Bone marrow aspiration and biopsy shows hypocellular bone marrow, no tumor infiltration, no increase in reticulin, colony-forming cells low or absent. Cytogenetic studies exclude pre-leukemia. In Fanconi's anemia, cultured peripheral blood lymphocytes show increased chromosomal breaks with DNA. Cross-linking agent, e.g., diapoxybutane. Investigations. Vitamin B12 and folate levels should be normal. Ham's test, classically negative in aplastic anemia and positive in paroxysmal nocturnal hemoglobulin, PNH. Liver function tests and viral studies to detect antecedent hepatitis, test for hepatitis A, B, and hepatitis C, Epstein-Barr virus, cytomegalovirus, and parvovirus B19. Paravirus classically causes pure erythrocytoplasia. Chest and sinus radiography. Hand and forearm radiography may be abnormal in congenital aplastic anemia. Abdominal ultrasonography, to exclude splenomegaly, anatomically displaced, or abnormal kidneys in Fanconi anemia. Complications. Bleeding due to thrombocytopenia, infection due to neutropenia. Failure of random donor platelet transfusions to increase recipient's platelet count, due to sensitization to HLA antigens from blood transfusions. Late clonal evolution to myelodysplastic syndrome or acute myeloid leukemia. In 10% treatment. Diet and lifestyle. Patients with thrombocytopenia should restrict their activities to avoid trauma and resultant serious bleeding. There are no specific dietary recommendations. Pharmacologic treatment. Definitive treatment is reserved for patients with diagnosis of severe aplastic anemia, 2 of 3 peripheral blood counts, absolute neutrophil count 500/L, platelets 20,000/L, corrected respiratory count less than 1%, with bone marrow cellularity less than 30%. Allogeneic bone marrow transplantation. For HLA identical siblings. Immunotherapy. Standard dosage antithymocyte globulin, ATG, 160 mg per kilogram total dose. Given over 4 to 8 days. Cyclosporin, 5 to 10 mg/kg/day divided twice daily given to ATG-treated patients for 3 to 6 months, or until time of response. Granulocyte colony stimulating factor, GCSF. 5g/kg/day subcutaneously for patients on cyclosporin until neutrophil count improves. Special points ATG, patients require hospitalization and monitoring during infusion of ATG for possible anaphylaxis, serum sickness. Prophylactic corticosteroids, acetaminophen, diphenhydramine may help prevent untoward side effects. Cyclosporin blood levels must be monitored. GCSF, growth factors should not be given alone for treatment of aplastic anemia. Main side effects: anaphylaxis, serum sickness, see special points, treatment aims. Transfusion independence, normal blood counts, normal bone marrow cellularity. Other treatments: blood transfusions, erythrocyte transfusions. To maintain hemoglobin 10-12 gm/dl. Platelet transfusions during ATG. Therapy to maintain count 20,000/L. When ATG treatment is ended, platelet transfusions are given to maintain platelet count 10,000/L or to treat bleeding episodes. Androgens, e.g., decaburabulin. Oxymethylone, not first-line therapy. High-dose corticosteroid, not first-line therapy. Prognosis: there is a complete or partial response to immunotherapy in 75% to 80% of patients. Late relapses of aplastic anemia following immunotherapy have been reported. Very young patients with very severe aplastic anemia have poor response to immunotherapy. Disease may evolve to myelodysplasia and leukemia, particularly after GCSF. Treatment, follow-up and management. Patients require follow-up until counts have been normal for 3 to 5 y.